Good morning, everyone, and welcome to the informational webinar on the impact of utilization management and documentation on revenue. Today, we're focusing on the residential treatment providers spreadsheet. I'm Kim Waterman, project coordinator at the California Institute for Behavioral Health Solutions, and I'd like to begin by going over a few housekeeping items. Due to the large number of attendees, all attendees are in listen-only mode. We do encourage you to submit your questions at any time during the presentation by typing your question in the questions box in your GoToWebinar control panel. You can download today's slides from the handout section, or today's handouts rather, from the handout section of the GoToWebinar control panel. We will also send these out to registrants by email at the close of the webinar. There will be a brief survey at the end of this session, and so we do thank you in advance for taking a few moments to share your feedback. We do read your comments and use them to inform future trainings. We will have two speakers this morning, Victor Kogler, Vice President of the California Institute for Behavioral Health Solutions, and Amy McIlvaine, Project Manager of the Thriving in the New DMC Collaborative. So I'll go ahead and turn it over to Victor Kogler to begin our presentation.
All right, thank you very much, Amy, and welcome everybody. We're on a fall morning here in Southern California. What we're going to do is I'm going to have some slides to sort of talk about the overall subject, and then what we'll be doing is spending most of our time, with the spreadsheet and the model for residential services. So with that, we will go right ahead here. Get this figured out eventually. Okay, so whoops, wrong title there. So this is for residential treatment. First off, where we start, I think as always, the starting point is the budget. How much money do we have to work with? And this is the budget which represents your cost of doing business as a residential treatment provider under the DMC ODS waiver, which is a lot different than what you're doing, say, a year ago. In the budget, I think, anywhere from, you got two major sections. You got staffing, and that's anywhere from 75 to even 85% of the total. Our work is, in about that proportion, person-to-person interaction. And then there are operations. For program services, you've got service delivery and staff activity. One other thing in the budget, which I need to add, is room and board, and we'll talk about that in a moment. So anyway, just a little more detail, the additional cost for START ODS participation, looking at how with the higher rates that is results in improvements in quantity and quality as well. Of course, you're limited in quantity because because licensing limits the beds in the facility. And then there's the importance of identifying staff who provide billable services or in this case, the service the 20 hours of staff-led activity that are required under your residential treatment license. In addition, you want to look at the cost of non-billing staff, outreach workers, compliance, quality assurance, director, clinical supervisor, etc. Room and board. As I mentioned, your indirect costs per the OMB uniform guidance. And then something to consider is the extent to which some of your costs may be subsidized or subsidizing other agency programs. And sometimes it's difficult to say I've seen provider budgets where the executive director probably correctly, but was in there, looking over half a dozen program budgets, totaled it up to, 1.4 FTEs, and that, that's not going to fly with an audit, even though that may be true or at least may feel like it. We need to make sure that all the costs shown are accurate, within the agency, not just within the program. All right, so I will. Flip over to the spreadsheet here, and we'll be spending most of the rest of the time going through this. We will pause occasionally, and Amy's has her eye on the question box, so Amy will jump in and say, "We've had questions," and then we'll deal with those. We've got a reasonably small group, so we can feel free to ask about anything, and we'll try our best to answer. So first off, we have the budget template used here was initially designed to correspond to the SAPC budget template. And as this model has evolved, and as has the SAPC budget template evolved, it's maybe not as good a fit as it was initially. But let me go through this. So you got your staff providing billable services and other required services. They should, in most cases, be the same because you're going to require at least a certified AOD counselor. So you got a program coordinator, your alcohol and drug counselor, counselor 2, counselor 1, MFT in the therapist capacity. In the outpatient spreadsheet, and this would be different in residential because I don't know that this would still work, but we have an AOD counselor with a bilingual differential. If you do have monolingual clients, you would have to, it's always, it's one of the unique things in residential treatment is, what kind of client mix do you have and how well do they work together as a group to help support each other in their early recovery. And if you have 2 people who speak a different language than the other 12, it could be difficult. So I took it out here, but there may be folks who may get a differential. Salaries subtotal, your taxes and benefits, if that's something other than 32%, you can put it in here, 0.28. And also, this is not protected, the spreadsheet, so if you want to, you can add additional rows. Just be sure you update the formulas, or you copy the formula. So you can make that work however you want. So anyway, these are the staff up here who are doing the work with face-to-face with clients, 7.5 FTEs. Down here you've got, for example, a clinical director, at least half of that MFT is in their LPHA and clinical supervisor capacity, not directly billable work. And you've got your finance manager, office QA, compliance, IT, an outreach worker, a cook. Maybe you've got a cook some places, some don't. You have a driver. Now there's some question where maybe you shift that up here to the billable because you can bill for non-emergency transportation. So you could, although I don't know, I would put it wherever you want that makes sense. I think it makes sense here, but night shift staff, often called monitors or program assistants, but these are folks who are basically, after hours, make sure, if anything bad happens, they know who to call. Then we have, and here's where we take a real departure from the SAPC template, but facility renter lease, your equipment, copier, the lease on the van, etc. Your direct and indirect operating costs, which as are instructed by SAPC, your indirect, and then room and board. And I didn't see that on the latest iteration of the template, and I'll just show you something here. Ideally, and this has been done in other counties, is clearly these people are all 100% treatment. You get into administrative type staff, cook would certainly be room and board. And then also the facility, more so here, your food, your household supplies, and in order to document what the room and board is. Now, if SAPC does not require that, then that's fine. However, there will be audits by the state. And, I think it's pretty much a given that for residential programs, one of the things they're going to take a look at is to ensure, and they'll do this in any audit, the drug Medi-Cal funds are spent on allowable activities. So you have to be able to describe very clearly to an auditor that the amount that you've paid or you've been reimbursed for room and board is very clearly delineated from the drug Medi-Cal reimbursed treatment day. So I recommend that for your own sake. Like I say, you're going to need to communicate this to a state auditor. There is a SAPC flat rate for that. We'll lay it out on the next page, I think. And so you want to make sure that that's very clearly delineated. This is one way to do it, but SAPC may have given you other methods for this, or you may have your own approaches. But it has to be very, like I say, clearly differentiated between the treatment services. So now we're going to look here. Any questions on the budget? Do we have anything, Amy, before we move on?
Yeah, Victor, if you don't mind, I'm just going to clarify a couple of things. So would you mind scrolling up to the top of the sheet? And again, these are just things that are common questions that I get asked when I go to help people fill this out. If you could scroll all the way up to the top where it says Schedule 1A. Yeah, there, you've got it. It's perfect.
Is that more readable, by the way?
Yes, I think so. Yes, okay. Much better. So again, Victor was, quickly describing that you have two sets of wage categories here. You've got one that are direct salary, wages and benefits, and then indirect. One of the things that sometimes people ask me is, what does FTE stand for? And that's a full-time equivalent. So you'll notice, for instance, that on line 6, Alcohol and Drug Counselor 2, Victor has allotted that there's 4 people working in the organization who have that title for a total of 4 full-time equivalents. It could be 4 people, it could even be 6 people, but it adds up to 4 full-time staff persons, and he's got the hourly rate here. I've worked with some organizations where there's some, like there's new hires that maybe make a little less than others. So you have the flexibility to add more positions in this first section because you can just add or insert a line, remembering again not to mess with the subtotals and the taxes and benefits. And then maybe, Victor, you could talk a little bit about taxes and benefits, that you've already inserted the 28%, but how people would calculate that. And then the other one that's sort of a critical one is the medical director, and if you would just tell people a little bit about, the disparity, is it a W-9 or is it 1099, W-2 or 1099?
Oh, okay. Yeah, many providers, for many providers, the medical director is a contractor, and so they wouldn't show up here with employees, but rather as a line in the operating or services and supplies budget, whatever we call that here, and as a contractor, and that's fine. But they are there, and you shouldn't think because you don't see that up here. That's you can just get an MFT and be done with it. And in some cases, the MFT, I don't know. Sometimes people have an LPHA who operates only as an LPHA. That could be a contractor too. So they come in several hours a week and sign off on treatment plans and diagnoses and such. Although other places, as I show here, the MFT could also carry a caseload. So.
Yeah, and I think that's a good thing to point out, is that maybe go into a little of the you kind of explain, like on line 21, the clinical director is 0.50 because that's has a master's in family therapy. So it could be that the person described on line 8 is a full-time employee, but they spend 50% of their time doing direct service and actually doing billable hours. And then in the bottom half, their wages are accounted for because they're doing some of the, they're doing clinical director, so they're doing training, they're reviewing case notes, which, may or may not have anything to do with getting billed. So you have to allocate some people in both the top half and the bottom half. Another thing that you can do is, if you have a person and you have an organization that has maybe residential services and you also have outpatient services, a team member may be shared in both agency types or sites. So you might want to just allocate half of their whole payroll to this residential template, if that makes any sense. But I always tell people, the bottom line is, if you've got your payroll register, everybody should be accounted for when you're done with either Schedule 1A or Schedule 1B.
And that's correct, and that people could be, for example, the program coordinator or the facility manager, oftentimes that's also the lead counselor, the senior counselor as well. So people get promoted from a counseling position up to a more management responsibility, but they still may have a caseload. So again, that could be divvied up between the two schedules as well. So maybe they're, could be 50-50 again. There's more management responsibility for keeping the house operations going, and another 50% for as a counselor. As Amy said, the FTE there is a full-time equivalent, and where you've got 4. That could be more than 4 people. It could be somebody works half-time, and you've got 2 people working half-time who are also employed in the outpatient arm of the program, that sort of thing. Again, with the hourly rate, if you've got folks who you've got a new hire versus some senior staff, average that out. This is not your this will not be audited, and it's a model. Like all models, it's not 100% precise, but close. And that's what I think is what you need to be thinking about. This is sort of shows you, it's like a map, and it's not, the map isn't the same thing as actually being out there on the highway. And so this will be the kind of the summation of your best thinking on program staffing and costs. Same thing with the taxes and benefits. Those are generally pretty straightforward, in terms of your payroll taxes, in terms of what your benefits cost, health and whatever else you might be able to provide for your staff. And you could actually do this in a way, if you're looking at, say, a different health package, then better health coverage, then what does it, goes back up to 32%. Does that look like? And what implications does that have for utilization and service delivery in the program? Anything else, Amy?
No, but we did have a question, and it really does, you kind of just started covering it. It's not so much a question as an observation. Someone mentioned that they did do this and they felt like they were really doing some estimation and not necessarily real confident in the accuracy of that information. And so I did note that, we being CIBHS, suggest that what you might want to do is, now that you've got, July, August, September, and October under your belt, billing under DMC, you might want to use those numbers to go in and just take the spreadsheet, because it's actually pretty simple to fill out. You could just fill it out for an actual month even. You could go back and look at, what are your costs for the past 3 months and do an estimation, and maybe just fill this out again and see how it matches up to your projection. But we certainly understand that there's a lot of estimating going on, and they also have some, identified that there's other modalities as well as DMC and non-DMC, and so it is difficult to kind of figure out, which dollars, which expenses, and which staffing is allocated to what. And I think then, Victor, you mentioned that it's good to keep good notes and make sure that you're documenting things so you have the backup if you do get an audit. But if you have any other good ideas to add to that, that would be great.
Well, I guess a couple of things. One, yes, you're right. I mean, these are estimates, but they're your estimates. And I don't know how we can do better than that. A year from now, we'll all be a lot smarter because we'll have actual data to work with. And, you can see from, as you plug numbers into the budget or elsewhere into this model, what impact that might have, on staffing levels, on productivity, et cetera, and can make adjustments. But I think, nobody's got, even though none of this is perfect, nobody's got better numbers than you do. And so that's the starting point. Secondly, we're here to help out. If you reach a point, you're looking at this and this just doesn't, it doesn't look right, or I don't, give us a call. And we've done one-on-one webinars with organizations, with the fiscal staff and the ED and whatnot, to go over this, or initially with the person who's filling it all out. So you've got we're here to help out, and if you see something that doesn't make sense, give us a call, and we'll work with you to work through it, so it becomes clear. Is that all now, Amy? Any more questions? And
No, that's it. You should be able to move to the next page.
Next page. All right. So we're looking, and I don't know if you were, I think there were a couple of people who were on the outpatient discussion Friday, and residential is a bit different, as we will see here. So these are the billable services, and as you may recall, the outpatient one ran, way out. Let me expand this a bit. So what we have here, and this is, I asked SAPSI about this. I said, well, what should I look at for the average duration of the episode? And they said 60 days. So that's why we go through 9 weeks. So first off, you've got your residential day rate at $109.28, your room and board rate at $46.96, and then case management billing of $33.83. And so this, shows the total units for the week, and this is, it's the units are days in 2 cases, and the other it's 15-minute increments. And then we highlight here the case management hours per week. And then at the bottom, we just have the totals. So somebody stays for 60 days. Again, this is assuming, the perfect client, that this is what look at 60 days of residential treatment, 60 days of room and board, 62 units 15-minute units of case management for a total of 182 units. Now, the units thing here, we're mixing apples and oranges. So, but here, the total cost is what we really want to look at. Is $11,472 per episode. So if everything works out, then this is what you get reimbursed. Now, how you might modify this, for example, is with case management, maybe there's more at the beginning, because that's the transitions in level of care are a function of case management. So maybe that's 12 units. Likewise, towards the end, as you are getting ready to hand them off to the next provider in the chain, that could be more. Maybe this is just way too much anyhow, and you want to cut it down to maybe an hour a week, who knows, and reduce that or increase it, as you wish. If you want to look at a different average length of stay, then you could, adjust here. Actually be more than, that's the problem since months aren't exactly 30 days. You get a little bit carryover. But, you just delete this. And then you've got a 30-day. You'd have to change this, I forget, to 2 days. But anyway, but you can, make these adjustments. Right now we want to look at, though, our, $11,000 per treatment episode of 60 days of somebody who continues for the full 60 days. And then your case management hours, which we'll use elsewhere in the spreadsheet. So do we have more questions, Amy? Because otherwise I'll just move on from here.
No, we don't have any right now. Yep. So far, so good.
Okay. All right. So again, this is your model. This is what the best case. And so now we'll look at revenue. And this is a little more. So this is for the billable work. The room and board, and we've got it here, residential treatment day. Let me expand this. So the residential treatment day, room and board, case management. These are the things you get paid for. If everything happens according to plan, you will gross $3.3 million here. And let's just go back here to the budget. And your total budget is 2.7. So, looks good. However, a couple of things, and is your vacancy factor. That adjusts things downward. We have that up here. Basically, vacant bed days per discharge admit cycle. After a patient is discharged, how long does it take to replace them? And that will change a little bit under the waiver because of the authorization requirement. Again, you're going to have to make your best estimate here. I don't know what it, what it was last year. We're 3 months into it, 4 months into it, almost 5 months. So you've got some experience under your belt. And so, is it 2 days? Is it 1.5? 3? But whatever, it's an important parameter. Because every day that bed is vacant, you're losing money.
Victor, can you change that number? Can you add a couple of different numbers to see how that impacts the vacant factor?
Yeah, sure. Yeah, so it's two. I'll use large numbers here just to highlight the impact. So let's say it's 4 days. Now we'll look here. This is where the You know, so right now at 2 days, you've got, you know, more than one bed, 500, I don't know, do the math here, but, you know, maybe 1.5 beds worth a vacancy per year. You know, so like 365 be one bed, you know, if that was occupied the whole time. So we take that up to 4, just so you see the difference. You know, that's 1,100 vacant days a year, and that costs you, you know, $182,000. So if you took that down to 1, which, you know, it's $45,000. But it highlights the, you know, the cost to you of vacancies. So the better you can do, the, you know, the better off you are. The other thing here is the disallowance and denial rates. You know, denials are when the claim is either not submitted to the state. So, for example, if you're using, Sage has the functionality of not submitting for reimbursement a visit where there's no progress note, or if the note's written but not signed or dated. So that's nice, because that's a big, people lose tons of money for little stuff like that. But if it's not signed, you know, we sign electronically, then it's just going to sit there. It's not going to get claimed. So that's one source. The other thing is, then you do submit it. It goes to Sacramento, and then it gets you get, you know, bed days that are bounced back, treatment days that are bounced back because, oh, the client wasn't eligible. There's a, you know, typo in the date of birth when you open the episode. You know, any number of things. Many of those are correctable, and I think, you know, if you get staff who can work those claims effectively and know how to remediate and resubmit and get paid for stuff that gets denied the first time around, are worth their weight in gold. And some things are going to be fatal errors. You know, if the patient wasn't eligible at the time services were rendered, you know, you're not going to get paid for that. Now, on the other hand, if you know, the client, the patient, let's say you bill for today, but they have an application in process, and and I have to say, I've done some work with a statewide eligibility file, and there's about 7%, which statewide is a big number, of people whose eligibility status at any given moment is not clear. And, you know, I talked to an analyst at the state about that. He says, hey, you know, there's so much activity going on. This is the way it is. You just, you know, you look back a couple of weeks from now, and it'll be much clearer for those people, but there'll be new people who we don't know where they, you know. And so that's why you need to resubmit. If, for example, the client gets their Medi-Cal card on the 27th, let's say, and they were admitted to your facility on the 13th, you can bill for that. You know, Medi-Cal eligibility is awarded in 1 month chunks, which goes back to the first of the month. So an important reason why you need somebody to in the facility to check out people's potential eligibility status and get them to you know, to social services, to the eligibility staff to get signed up, because then you can't get paid for that. And of course, if you don't, then you don't get paid, and you don't want to, you know, discharge somebody for that reason. So anyway, so, you know, where we are here, so there's 10%. That's, you know, I've talked to some people one person from a county mental health program who said, oh yeah, we're only 2%, which I thought was pretty interesting. But, you know, but it makes a big impact. between difference between 2 and 10%. And of course, if it's higher than that, you can see it really is not good. So you really want to keep an eye on that. Denials are the post-service, post-payment reviews. Those are going to be pretty straightforward for residential services. It's not so much, outpatient's got a lot more moving parts, a lot more stuff going on. Here you're just billing for a treatment day. Were they there or not? That's kind of it. You want to make sure that most of the post-service, post-payment disallowances are related to clinical documentation. All of that is under your control. I think SAGE will go a long way to helping to correct that, but still you're going to need somebody looking at those charts. Do you have notes in there at the right frequency? So anyway, if we look at all this, you're actually, well, we'll go back to 10, but you're actually 200,000 to the good. So that is good to see. Now, what that means in terms of your billing is maybe, well, first off, I think when you see this, you think, okay, we got an extra $200,000 to work with here. Is there something we can do to, beef up the staff, provide other sorts of stuff? Maybe we, lease or purchase a new freezer. Oops, no, we can't do that. I take that back. That's room and board. Some new equipment, like I said, maybe a van. That's you got to get a lease on a van that's not falling apart. That sort of thing. So, and if you take a look at that, and you say, okay, well, that's then I think, and I don't, again, I would have to defer to SAPC's guidance on this, but you may want to then bill at a lower rate, because you don't want, if you read the provider manual, cost reconciliation is the lesser of cost or charges. So if you bill for more than it costs you to provide the service, as this shows will happen, that you'll bill for $200,000 more than your cost if you're billing. We'll go back here at the full 109.28. Then you're going to have to pay money back. If it happens, you bill for less than your cost, then you've, what's one of the basic rules of Medi-Cal, of Medicaid? It's a federal thing that, that the provider agrees to accept this as payment in full. So if your costs are in excess of the amount that you bill, you have to eat it. That's just, So with that, I want to go just back up here to the top. So we've got the episode duration, the numbers that are not, the numbers that are highlighted are calculated. And so mess with those at your peril. But the direct service staff FTEs comes from straight from the budget. Episode duration, you can plug that in yourself. However, if you change that to say to 30, you're going to need to change this to 30. The individual session is an hour, group session an hour and a half. That's just, standard stuff, but you could change it if you want. License capacity, whatever that is. I just put in 48 here. Average drug Medi-Cal attendance per group. Groups in residential, all group counseling, whatever the setting, has to have between 2 to 12 participants in the group. And so what's your, and I'll show you a little bit later what the impact of that is. So that's kind of basically it, as far as what you're looking at your revenue and some of the the factors that impact that revenue. If you're we can't just change these things willy-nilly, because then if you say, well, we've got 60 beds. There's a lot more money there, if you notice that. But also, you're going to need to change the budget as well, because you're going to need more staff to handle 60 clients at any given time. But again, this shows you what, and for example, you do have 60 beds, but 12 of them are in an AB 109 contract, let's say, and the 48 are in drug Medi-Cal in the same house. You're going to want to be able to, again, clearly differentiate those, and this is could be useful in this regard. If you want to look at, what's the facility as a whole. There's nothing that prevents you from saying, well, I'm going to look at the entire operation here. This would be drug Medi-Cal, this would be AB 109, and maybe some CDF, CFS money. Fine. You can use it to see, okay, here's what the entire operation is. Some of the stuff, disallowances only apply to the drug Medi-Cal part, but those could stay. You may need to prorate those a bit, because if drug Medi-Cal is, 50% of the operation, 10% disallowance rate would be 5%. If you got the entire organization, or maybe you take that out and don't even look at that yet. You just want to see best case how this plays out. So put that back, and but that is so. Anyway, so that's basically it here. So, Amy, do we have anything at this point?
No, we don't have any questions. I'm just going to follow up with a couple that I get routinely again, and just also just kind of make a suggestion. If you do have a pretty complicated breakdown of your license capacity on beds, maybe you have 2 or 3 different, accounts that you're billing under or whatever. I personally don't think that this spreadsheet is that difficult to fill out. Once you really get a hang of it, especially for residential treatment, because you don't have as many moving parts as you do for outpatient, I would suggest, kind of doing a little bit of an estimate to see how those individual payers actually combine to make a whole. So if it was me, I might say if I have 38 DMC beds and I have 12 AB 109, I might fill this out for both, just because I think that would help me really get a good idea of what it is that I'm spending, and I could start to do a better job of estimating, and at this point it feels like guesstimating. So yeah. I might offer that as a suggestion. Somebody who used to have to adhere to a pretty rigid P&L with very little disparity. I had little or no flexibility in what I reported out. I had to be pretty accurate. So if you start to break this down into smaller parts, you might be able to watch something a little bit more specifically without too much trouble. The other thing, if you can go to the top of the page, we did have a question last time about the 1 and the 1.5 for an individual and a group session, and let's just kind of help people figure out what you do here. Victor has it calculated on the billable service model that an individual session is 1 hour, and he put in group sessions at 1.5 hours. On our last call, someone said, well, some of their group sessions are 1 hour, some are 1.5, and they weren't exactly sure how to really manage that on the 2 spreadsheets. So would you just do a little brief tutorial on that? What 2 places you have to shift that and how you estimate that?
Okay, so if, for example, you've got a mix of groups, then we could. There are ways you just say, and maybe the average. So you got some 1 hour groups. You got, maybe you got some half hour check-in. or I'm sorry, I'm talking about groups here. You know, so maybe some are an hour, some are an hour and a half, maybe overall it's 1.25. And that rounds up, I shouldn't. So you can, take a look. You can adjust this according. Same thing with groups. Maybe you got, or individual rather. You got, some half-hour check-ins, some, whatever. And so, maybe it's 45 minutes overall. The thing is that I think even though people are saying, well, we're using the word guesstimate a lot, it's a starting point. And if things change, and we recommend using this as a basis for monitoring activity, moving forward, is okay. What does reality tell us? Like you get the map, or you're looking at your, print all the stuff out from Google and to find out, oh, this off-ramp's closed. There's construction. Then now what? Same deal here. Is the model need adjusting? So maybe it doesn't. The off-ramp will be open tomorrow. But maybe program practice needs to be looked at. Maybe it's just, random happenstance. And I think that's what needs to occur, is not to say, okay, this is it, but rather to monitor program activity and performance against these initial benchmarks. And you may find it changes, that your average group duration is whatever, is more or less than you had thought. Then you can change that. So there's all kinds of, you shouldn't look at it as something you do once, you look and that's that. I mean, just really, it requires not only your best thinking putting it together, but your best thinking, in practice, is thinking, okay, what we see this month is different from what was in the model. Why? Were our assumptions too optimistic, too pessimistic? Did we get a bunch of clients from, from wherever, from the jail, who were, not very happy to be in treatment and split as soon as they could? It's this question of it gives you a structure for thinking about what you're doing and to adjust either the structure or what you're doing to make things fit better, to optimize it so that you're not losing money, basically.
And then just real simple. And sometimes people weren't even really sure how to actually fill that group session out. And what you can do is just add up all of the 1-hour sessions you have, and add up all the 1.5 hour, and add up, some people even have 2-hour sessions or 3-hour sessions. Add those up, and then you have to do a little bit of math, because you'll have to take the total number of time and divide it by the number of groups. And then you'll get your average group session hours. That's how you would figure out if you do actually have a 1.5 or 1.25. And then, Victor, would you show them where they need to change that on the tab in the billable service model? Because that is something that is calculated also on the other tab. You've got it already set for 6 units, but they may want to adjust that according to their capacity in the billable service model.
Well, actually, this would, you could change this. This isn't really duration, but number of units. But if the, say, case management session, so I've got 2 hours worth, maybe you say, well, really, case management is only, we're going to do it in, 30-minute pieces. We'll do 1 hour at the beginning, 1 hour at the end, dealing with the transition and level of care. But, normal course of business will be half an hour. Well, then you modify this accordingly. So it's like 2 1-hour sessions. Well, it's actually 2 half-hour sessions. Then that would be 4. And you change that. And again, I will probably say this a few more times. If you have questions, give me or Amy a call. Whether you want to look at using this for your entire facility and you've got 3 different contracts going on, let us know. We'll help you put this together. It can get a little complicated. I mean, the first time you use it, you're thinking, oh God, how did I do this right or whatever. I had somebody call me and they said, that they believed it for about half a second, but their revenue page like this showed they were going to gross $31 million. And anyway, they made a pretty significant error in the previous tab and overstating the number of clients that they were going to see. But it's that kind of thing. Anytime you're filling in a field somewhere and you get a result that looks wild, pick up the phone, shoot us an email. So anyway, so that's it. We'll show you. We'll move on to the next tab here if there's no other questions.
Victor, just for clarity, do you want to show them? Do you want to show them how the dynamic capacity is calculated? Just because I know that's kind of a new term for people also. Thank you.
Oh, all right. Yeah, thank you, Amy. That is all right. So you've got 48 beds, and if your average length of stay is 60 days, 2 months, those will turn over 6 times per year, right? Again, this is an idealized model, and some so then it's basically 6 times 48 is what your capacity is. And so that, and you can see the formula here, so that kind of, you hit F2 and it highlights the cells. And so really it's a function of your license capacity and the duration. And so that would, again, under optimal circumstances, the total number of people you'll see per year. Now that actually will be pretty much, will be higher, and we'll see if we have time to get into these, but really that is a matter of client engagement retention. I was looking at a state report here, and it shows that 65% of people admitted for residential treatment statewide, this is in fiscal year 15-16, that 65% stay 29 days or less, and that, which means that 35% stay 30 days or longer. So there's a lot of attrition at the front end, and some of you may know, may see what I'm talking about in your own organizations. A lot of clients come in, and 2 weeks is about is a big dividing point. Many leave in the first week, and for whatever reason, this is not what they, who knows what, but they're not a good fit for them. So that's how we calculate the dynamic capacity. So the static is easy. You count the beds, look at the license. That's truly static, and that's not going to change. But what that means is if the turnover, again, is 60 days, and then you'll see by year's end close to 300 people. If we're to change this, we'll go back to the old 90 days. You see how this goes down to 195 from 292. If we change it further, say to 30 days, it takes a big jump. So that's it. So anyway, so that's what how that works. Caseload per FTE, that's basically, you got 48 beds, 7.5 FTEs. divide beds by FTEs, you get 6. That's 6 point something. Because you can't have fractional clients. So, all right. Anything else?
No, I think that was it.
Okay. All right. So on to the next. Now this is different from what we had in our outpatient model. This is required services. So you bill for the treatment day. You bill for case management, but you've got to provide 20 hours per week of staff-led activity. And this is how that lines up. Now, I suppose a disclaimer I should have said at the very beginning, the numbers I put in here are based on, the budget, based on an actual outpatient provider budget from the Bay Area. But in other cases, like here, I need to populate the model here so I can show you all what the output, what it will tell you. And so I plug in stuff that looks reasonable, but and so basically what I was looking for was to get, this is my target here. I had to get 20 hours a week. Last week you only got a couple of days, so it's 12 hours. So, and basically I loaded it up with group. So we got 48 units, which is, 8 groups per week, the first week. So I don't know. This is, you're going to have to see how this looks for your organization. Here's 80 units of group. So, it's a lot of time. So maybe this gets spent elsewhere. But, it's tough to say because the, group services, so group counseling, patient education, basically it really is where you use your staff most efficiently. And we'll see this in a moment, but you do a group with 10 people, or rather, so you got 48 clients, and let's say the house is full. You do a group with an average attendance of 8, that's 6 groups. If you do, if you max out the groups at 12 each, you're doing 4 groups, which means instead of 6 times 1.5 to do the 8-person group, you're doing it only 4. It's 4 times 1.5. And so you see you've got extra staff time available, and you can deploy staff for other activities. So that's really, I think I found this a little bit challenging because I thought, well, is this really realistic? I have to say my own personal experience has been much more in the outpatient realm than residential. But the real challenge for residential services is, do you have enough staff? You add this all up and you get, 172 hours a week. So this is what your staff are doing. And so do you have enough staff to provide that level of activity? And we'll see this on the next tab. But does anybody have any questions or comments on this? Because I think, like I say, just to demonstrate the model, I had to make sure I was getting 20 hours a week here. But whether this amount of participation in group counseling is at all reasonable is a big question for me.
Yeah, Victor, I would have a question too. I don't know if people have time to sort of, ask us specific questions, and you can just do that by entering a comment in the question box. But again, I think this is something that, would be this little sheet just to track this individual tab would be a good idea going forward. You could even look at, the last 2 months, because I know a lot of people who are in residential treatment, that's one of the hurdles is, really how do we train the staff and how do we allow them the time to sit down and actually enter the documentation and to actually, specify exactly what it is that people are providing on a day-to-day basis for their customers. And some people are, having the person who leads the group enter all the notes into the computer and write it down. In other places, there's a case manager, not a case manager, but whoever caseload it is, they may be the person that actually enters the individual service units in. But to me, this is probably the thing that's newest and could be perceived as most complicated. And what you could do just for like a rapid cycle change, the airplane exercise that we did at the network collaborative is, train 1 or 2 of your staff to really track this information and talk to them about what their hurdles are, try to get a system down, and then take that information from them tracking to really kind of start to look at, what does your patient-centered care look like in your organization? Again, Victor has this filled out right now to kind of make sure that you're meeting all your minimums, but you can also see there's such variance in, the types of services that you can provide. So this actually, improving that process is a great PDFA cycle.
Right, and you could use, if you want to, you can take out my numbers here and just put in your actual numbers for your entire caseload. For you want to put maybe dates or something here for, and make it, go down to 365 days, and tally that up. So you, again, this is how you see whether this model, which represents, your best thinking on what you're going to be doing, how that's in sync with actual service delivery. So you could convert this very simply, and we could do it for you. It's, into a tracking sheet. At some point, you should be able to get this out of Sage. Whether that'll happen, in December, we're not sure, but you need to be looking at this, because it's not just being able to keep your facility running depends on this. If you need, well, let's just see here. So you've got a budget of so we'll go this divided by 12. So you need to bill $229,000 every month. And if you're not getting that, then you're running a deficit. And this is what will tell you that. If you set this page up as a tracking sheet, aggregate everything, by week, because you will know, by week, by month, what your target is, and you can aggregate that for the entire caseload. And if you're hitting that, great. If you're exceeding it, that's great too. But if you're not, then you need to take some action. And in some cases, again, with residential, it's simple. I mean, how many people are in those beds? That's the first indicator. And, but there may be other, who knows, scheduling issues. How in the world do we do all these groups? I've talked to people running residential programs who say, it's like, there's probably 2 days a year when everybody's in the house. Otherwise, it's, it's to the doctor, it's to the court, it's to the probation department, it's to the Medi-Cal office. They have vans in constant use, taking people to various sorts of appointments. And of course, if they're not in the building at the time, then you can't chalk that up to meeting your license required services. So Again, just this is a good model for not only for setting up what your projections are, but for tracking your actual work to see whether, if there's any disparity, and let you know what sort of action to take. So, all right. Anything else, Sammy? We'll go on to the next slide here.
I think we're ready for the next tab.
Next. All right, yeah, next tab, not next slide. Right. So anyway, this is all calculated here, and the big issue is what this tells us. And we'll just go here. Do we have, out of our 7.5 FTEs, enough staff hours per week to provide all the required services? Where this starts, and these are the three numbers you can plug in here, is the hours per FTE for paid leave, so that's vacation, holiday, vacation, holiday, etc., sick leave, whatnot. There is program support activity, and that's basically, well, let's go here. The direct services, so that is direct interaction with the patients. That's providing the group counseling and any of this other stuff, and then whatever is left is the program support, and that would cover, charting, documentation, phone calls to the probation department or whatever, that kind of thing. And so clinical, case conference, clinical supervision, on and on. So that's it, but they got to spend, the estimate here is like, 2/3 of their time doing direct services, doing the required 20 hours per week per client of staff-led activity. And so, based on the model here, which are your numbers, we see there's 27 hours a week in direct service. If taking the total direct service FTEs from the budget, 7.5, we end up with 10,500 hours for direct service. 15,600 total. And from that, now this is on an annual basis here. This is annual. Is we get 202 hours per week available for direct service. This is based on a 67% productivity. The 1,400 hours you indicate is where you expect them to be interacting with clients. However, what we see here is that the target is 303 hours. To do everything that you said here is going to take 303 hours a week to do that for everybody. So that's, and here is the sort of where this all boils down to, is you don't have enough staff to cover that. I think looking at counties and providers around the state, this is the big challenge for residential programs, that there's more structure to this than there used to be. There are providers, these are other counties, but who have, and this is like the integral facility concept, so they have multiple small 6-bed houses, and everybody comes to a central location in the day for treatment. So it's really kind of sober living plus intensive outpatient, or at least that's one way to think about it. But with the drug Medi-Cal certification that they're going to have to do in order to keep at least what seems to be emerging from the state, is that each house is going to have the activities provided on that site, because the certification is provided to that specific address. You know, DMC certification is done on a per facility basis. And so it's a huge challenge for folks, you know, running programs like that. And because there's more greater structure in terms of the types of services that are to be provided in residential, this is challenging. You know, we've seen programs where they do like a house meeting. You know, so all 48 people are there in the day room or the dining room, whatever. That's fine, but it doesn't count. There's other things like that, where long-standing, you know, features of certain programs that don't count towards any of those required services as they're outlined in the waiver. So that is where the big challenge is, I think, because residential, being more structured in some ways, isn't quite as fluid, dynamic as outpatient treatment can be, but it also you know, has some very specific service provision requirements. So in this model, which I say are numbers that are you know, sort of semi-random, not entirely though, what we come up with is a scenario where, based on 48 beds and 48 clients, that this is the type of service, you know, what we need to be providing. 303 hours a week, but we got staff to provide 202. Now, one of the things you could do here, so where we go back here, group session, average drug medical attendance. So we have 8, let's say it's 12. Again, using the staff more efficiently. What happens? We're only 67 hours out. Much better, you know. And so that's, you know, that's where it's important to look at, you know, how then do we, you know, are there changes to make? So, you know, that's a big one. The attendance per group, if we take them down to 10, we'll go here, and we're 81 hours short. So, you know, this is I think the key, what this spreadsheet boils down to. I mean, one of the couple of things, but is, you know, is your staff deployed in a way that enables you to meet the requirements established by licensure and the drug Medi-Cal waiver. And then, you know, once you know that, then, you know, then is a question, all right, you know, for management is, do we have 12 people in every group? And that's the, you know, that's the question. And then, of course, some will say, well, easier said than done, because, you know, a third of the residents are out, you know, looking for a job, you know, doing all the other stuff they do, instead of just being in the house all day. So that's kind of it. I think the big issue here is, you know, staff availability, being able to look at what staff are available to do, the required services, and what that looks like. Your model may well be different from what I had here. The revenue forecast, just to make sure you're going to bill enough money to, you know, make payroll and everything else every month, which you will. In this case, you will. So that is it, really. I think, again, I could. Do we have any questions on this, Amy? I may just flip back to the slides quickly.
No, Victor, there's no more questions.
Oh, okay. Because really, the other thing that's going to be important is the engagement and retention. And, this I basically reworked from the outpatient model to residential using the statewide Callum's figures for retention. So 800 people will make an intake appointment, and, and only 280 of them, 35%, will stay for 60 days or more. And I think that's what kills people in outpatient, and will really do it in residential, is you've got your staff, because again, it's demands on staff time. And if they're spending a good chunk of every week doing intakes, assessments, treatment plans, etc., for somebody who's going to be gone in 10 days, it's all that churn is just a horrible waste of staff time. And the extent to which you are able, so it's not just strictly a numbers game. You think, well, okay, but there are things that you can do to improve engagement and retention. And I think that's, particularly in residential, is going to be a very important area for process improvement. And some of the things you can, you got nice facilities, you got nice staff, it's, also competence. You've done walkthroughs, been through the process yourself. Is that something you'd want to do again? Motivational interviewing, client focus groups. What would make you stay? Talk to the clients. And you may have limited abilities to do this, but I find from basic Tiller approach based on readiness for change, but I've seen, talk to people in some residential programs that are extremely challenged by, you've got a, sort of a good chemistry in the house. I mean, you can't bill for that, but it's extremely important. And you've got, so you got a group where you got some people who really, been there for a while, they get it, and they're really trying to work on turning their lives around. And then you get a couple guys just out of, out of state prison, out of jail, whatever. They don't want to be there. They don't care. They're, and it really brings things down. And so how can we do that? Do you have, if you have enough, and it really depends what operations are like. You have enough new clients, then you have a special newcomers group. They learn what it means to be in treatment. And for those that are negative, that are, that they're not infecting, if you will, the clients who are struggling and trying to work on their recovery. The other thing is, applying and test research findings. We know, I talked about this a bit at, last week, 2 weeks ago. Well, we know enough about, I think things are still evolving, but from what we do know, that's something you can test in your own facilities. How do we, sell recovery, sell our particular approach in this program, our staff, so that the patient thinks, yeah, I'm in the right place. So anyway, so this is, I think it's going to be a particularly important issue in residential treatment, is how do you engage people? So anyway, just to, I think bring it all together is the budget's going to reflect your accurate costs and complete costs, particularly if you've got multiple funding sources. It's clear between, Medi-Cal and 109 and whatever all else, who's paying for what. That you've got the patient encounters, the required services respond to a general model of patient-centered care that you've got, and that's what was on the service model tab. Optimized with regard to counselor caseload size and hours spent per week providing billable services. We saw that on the last tab. And, you know, is then tracking over the course of the year. I'd say, you know, every month you can even track it, you know, weekly to get the total billable units are bringing in enough revenue to cover your costs. That you take ongoing steps, I think, to improve retention, engagement and retention, particularly early dropouts, which you know is a huge issue. No-shows doesn't really apply so much. If they don't show, they're gone. And the staff need to be aware of productivity standards. You know, this is something everybody's got to plays a part in. And that the staffing complement generally is adequate to meet anticipated service needs. As we saw in the spreadsheet, is probably, you know, we made a big improvement by increasing the average attendance per group from 8 to 12, a significant improvement. But you still might be a little bit light. You know, you were 67 hours per week short. So, you know, you need to make sure that there's enough staff on hand to do the work. And most importantly, that you collect and analyze data. You know, that like some of these pages can be tracking sheets. You could easily modify this to so that input on actual, you know, weekly services gives you output on staff productivity, staff hours, etc. But that you collect the data that enables you to analyze, you know, this complex interaction, you know, of patient behavior, staff activity, and finances. This again, it's just a this is an initial benchmark, and you know, it's not. The model gets smarter. We all get smarter as time goes on, and we've got real data to use. And I think that's what's important about the tracking, because that we don't have to wait till next year before we see what the results are. So that's it for slides and spreadsheet. We can go back to the spreadsheet. We've got time for questions if anybody has anything. So
yeah,
Amy,
Victor, I think no, we don't have any more questions, and I think we're getting to the top of the hour. The only thing that I would like to add too is that Daniel's been sending out a lot of notifications about really identifying who your data people are going to be, who's going to track data, your key performance indicators, and some of this information on the spreadsheet will be really good things to kind of think about, because chances are you'll be able to pull this information out of Sage in some way, shape, or form, your disallowance rate, your no-show rate. You'll probably be tracking your caseload, episode durations, vacant bed days. So kind of, if you know, you might want to take a peek at this spreadsheet, and when you go to one of those meetings, you might want to ask people, how am I going to track this? Because this is all really important information that you will need for both revenue and capacity and productivity.
Okay. Well, I think it's just as a parting comment, I think I want to thank you for hanging in there. But you know, the most important takeaway is we're here to help. So as you get into this, you know, contact Amy or myself, and we'll walk you through any areas that you know, where you may need some help. So I want to make sure this works for you.
Yeah, definitely.
All right. Well, again, thanks a lot. We appreciate you joining us here this morning. More to follow, and stay in touch, and we'll talk to you all later. Thanks a lot.
Thank you. Bye-bye.